Welcome to EMDR Chat with Curt and Michelle. I'm Dr. Curtis Roundson.
And I'm Dr. Michelle Gottlieb, and we're so glad you're here. Curt.
Yes, Michelle.
We've been getting a lot of questions, and this is actually a common question that a lot of people ask.
Well, what is that?
That's, this whole EMDR therapy thing, it's really too good to be true. People are just saying they're at 0-7 clear, SUDS of 0, VOC of 7, clear body scan, because they want to make us, the clinician, happy. But it's not real. They're not really getting better.
Yes, I know. That's interesting. And since one of the things that we use in EMDR to determine whether there's improvement is we use these subjective measures like the subjective units of disturbance or distress scale 0 to 10, and we use the validity of cognition 1 to 7. And yes, that was, by the way, that was one of the criticisms of Francine's early studies, that she only used subjective measures, and that put into question her results for a long time. But I want to put this in a little bigger context because I love this question. I'm a little nerd when it comes to the history of psychology and psychotherapy.
And that is true. You are.
Yeah, because I taught those courses for many years. And people forget that the question was asked not about EMDR, but it was asked about psychotherapy, period.
This is not a new question.
Oh, no, it's from the very beginning. Does it really work? Or are people just telling us that to please us or whatever? And part of it goes back to 1927, 1932, with a experiment that was done in the Western Electric Hawthorne Works factory in Cicero, Illinois. And it was basically on work conditions. And look at this. This is between World War I and World War II. And they were looking to see if working conditions, if they changed the working condition, would it increase worker morale, worker output, the better lighting, better condition, all this stuff, things we take for granted today, but they were looking into it. And so they increased conditions, and then they had a group where they did not. And the interesting thing was, it didn't matter the conditions that the workers were in, better conditions or worse conditions. The very fact that they were being observed by someone else increased their overall attitude and output. And it became known as the Hawthorne effect, a psychological phenomenon where individuals will modify their behavior, like our patients, often improving their performances simply because they're aware they're being observed or monitored in our work.
Right.
That's one, but that's not all. The other one was done, fascinating study done, I think it was 1965, called the Rosenthal effect. It came from a study called Pygmalion in the Classroom. Pygmalion was the Greek myth, where he fell in love. He was a sculptor, and he made this beautiful woman. He fell in love with his own statue. And he loved her so much that at the end of the story, the statue becomes alive, real. And so they did this thing in a classroom where they randomly took students, gave them an IQ test, told the teachers randomly that these students would be on the edge of intellectual bursting of creativity and intellectual heights. And at the end of the year, randomly selected, each student that was selected had an increase, because the teachers showed an increased interest.
Right, regardless of what their actual IQ or creativity or whatever it was.
That's right. And so this was part of the reasons why in 1952, Hans Eysenck, who did another study, who said psychotherapy was not effective. Because he took people in therapy and then people on waiting list, and after 2 years, they had equal outcomes. And so he said psychotherapy wasn't effective at all. And that stood for about 15, 16 years until one of my professors, when I was in my doctoral program, Alan Bergen, checked it out, went to the original statistics and research data, and found that, interestingly enough, it was done in such a way that that's what the outcome showed. By using different statistical measures, guess what? Psychotherapy was 2/3 effective. And then they discovered that people on the waiting list weren't on the waiting list. They went somewhere else. They went to a pastor. They went to a rabbi. They went to someone they cared about. They got what called natural helpers in the working environment. So having said that, it's what often began the impetus for empirically validated treatment that we talk about today. Does it really work? Well, those are things that we have to ask about all therapy. CBT, prolonged exposure,
mindfulness, whatever.
Mindfulness, what is it? Is it the expectations? So let's put that in context before we get down to the specifics about EMDR.
Right. And we do know from all of the research that merely having someone care
Yes.
creates change. We also know just by asking a question and paying attention to a specific thing is going to create change.
That's right. And this is where Carl Rogers comes in. Again, historical fact.
Yeah.
He looked, and Rogers was the one that said that if therapists had 3 characteristics: warmth, genuineness, and accurate empathy, therapist characteristics, that regardless of theoretical orientation, there was improvement in the patients. Isn't that fascinating?
Right? Right. And
So,
just as an aside, by the way, Carl Rogers also said, all I have to do is walk in the room and clients get better. And he was not saying it about him that he was that fabulous. He was saying their expectation, I'm seeing Carl Rogers, oh my God. And so they would get better.
They got better. That's right. So this is a question, just want to put it in context, that was applied to all psychotherapy, period. And I will say, let's give the short answer. If the therapist has expectation of the client improving, yes, that can help the client improve. And the very act of having someone look at them and be concerned with them and ask them those questions, Michelle, like you said, yes, the client can improve. Yes, that's true. However, how does that impact EMDR and the measures we use? That's the bigger question.
And I want to, as we talk about this, I want to talk about, because we have them now, the longitudinal studies, because things changing in the session, that's lovely. But do the changes hold?
Yes. And that I can go all the way back to 1995, when Tinker, Wilson, and Becker did one of the first comparison studies. It was published in American Psychologist, showed EMDR at the end of the sessions. They didn't even meet the criteria for PTSD. And they did, I believe it was a 3 and 18-month follow-up, and then I believe there was a 7-year follow-up. And what they found was that the targets that had been originally target memories originally focused on in those psychotherapy EMDR sessions, still those many, many years later, had no charge. Now, other traumas could happen,
Sure,
and cause problems, but the ones that they had worked on still had a 0-7 clear effect. And that's been consistent since the very beginning.
And let's just add, it's not only does it show that those original target memories did not have a charge, and they were I just lost what I was going to say. But they didn't meet criteria for PTSD anymore. But also, not only did they hold, they actually improved.
They improved.
Yeah, at the end of session, which we don't typically see with those longitudinal studies with other therapies.
That's right. And it increased the resilience for them in future issues.
Absolutely. So, in session.
Yes.
I'll say when people ask me when I'm training, but are they saying this just to make you happy? And one of the things I say is apparently my clients don't really care about making me happy, because once our clients get what EMDR therapy does for them, they no longer care about making you happy. They go from, like on a SUDS, a 4 to a 3.5 to a 3.25 to a 3 to a 2 3/4. Because if it was really about making me happy, they go from 10 to 0 really fast. So apparently they don't care about making me happy.
That's true. And, and some of our participants, they have some very legitimate concerns, when they see EMDR, particularly in the trainings, when they actually see shifts happen very quickly. And this has not been true in their old paradigms. One of the first things that we do is begin to question the method itself. Well, they're just saying that because, right? Mm-hmm. And things like they want to avoid reprocessing. They don't believe it'll work. They don't think they're, that they're going to, they think they're failing, all that kind of stuff. And that's true. We address that in the beginning of EMDR. Clients often think that. And in EMDR therapy, one of the interesting things that's different is we just simply have them notice that and go with that.
Right.
Because often they're projecting immediately on the methodology what is often a common negative, irrational belief. I'll never get better. I'm too broken to get better. I'm beyond, I'm defective, all those things.
If I open this up, it's going to overwhelm me.
Oh,
I
yeah.
will die. Right.
I will die.
Right.
Yeah. I'll lose it. I'll go.
I'll start crying and never stop.
Never stop. I'll get angry and do something horrible.
I'll be like my mother or my father. Right?
That's right.
Right.
That's
So
right.
all of those things, those are what we call blocking beliefs.
That's
and
right.
we can target them. We can do cognitive interweaves. We can do all kinds of things to help move it through. It doesn't mean the therapy isn't working. The therapy is working. It's doing exactly what we want it to do.
So let's get down to brass tacks now.
Okay.
All of that being said, all the context, all the real reasons why people may think they're just telling us they're getting better. How do we know?
Right. So this is another reason why I love Phase 8 so very much. Phase 8,
This is your favorite.
This is my absolute favorite. This is Phase 8 reevaluation. This is when we did reprocessing last session. They come in this session. The first words out of my mouth, what's different for you since I saw you last?
That's right.
And they may not even have really thought about it, although my clients get used, they know I'm going to ask them that question, so they think about it on their way to session. But what is actually different? That nightmare I've had every night for the last 20 years, I haven't had this week. I was able to look my boss in the eye where I couldn't even be in the same room with him. I was able to say no to my partner. I was able to, and one of my stories I always tell because I love it so much is I had a client who came in and I said, what's different? He goes, I don't think anything's different. And I said, I happened to know that his wife was an EMDR therapist. And I said, go ask your wife. He came back the next week and said, apparently I'm not as angry as I used to be.
Mm-hmm.
Right? Changes happen.
And just like you said in that example, oftentimes the patient is the last to really see.
Mm-hmm.
Let me give you another example, okay? Just this week, I was working with an individual who had been extremely depressed for years and has never been diagnosed as depression. It was labeled poor motivation, all the stuff that, you often get from when someone is severely depressed. And so I had a psychiatric referral, and they put him on antidepressant, and he immediately began to feel different, which is unusual on antidepressants, right? However, he came in, and he says, "I don't think the med's working." I said, "Really?" "Yeah, I know. I don't think so." I said, "Well, tell me, how's your sleep?" He says, "Oh, I've been sleeping through the night. Previously, he was insomniac." "Oh, that's different. Yeah. How's your appetite?" "Oh, yeah, I feel like eating now." "Okay. How about your concentration? Your ability to remember?" "Oh, yeah, I could focus a lot better." And I just looked at him and says, "So it sounds to me like the meds is beginning to work." And he looked at me and says, "Oh, but my mood." And I said, "Your mood's the last thing that changes with those medications. It's all the vegetative things that change first. And EMDR, it's the subtle organic things that happen. And sometimes it is helpful to have an outside person say, have you noticed the difference?"
Right. And that's what we talk about is those changes can be so profound, so deep. It's like I've always been doing it that way. I don't know what you're talking about.
Right. That's
and
right.
so they don't even notice it, which just sounds so weird. And it's not until it's like, well, wait a minute. I had a client I'm working with right now who is terrified of flying. Absolutely terrified. She had a really bad flight, terrified of flying. And during the reprocessing we were doing about a flight, she lives in the flight path of John Wayne Airport.
Oh.
And a plane went overhead. And so during the reprocessing, she stopped and goes, "Oh, there's a plane." I said, "And how are you?" She said, "I'm fine."
I'm fine.
Go with that.
That's right. Those in vivo opportunities are so great.
Right.
So great. Another one I had recently, a gentleman was coming in for EMDR, and he had been talking to his wife, and he says, I don't know, I think this may be my last session. I don't think this stuff is working, And she says, "Oh, you better not be this last session." And he says, "Why?" He says, "This is the most present you've been with me in months."
Right.
"Oh, yes, you better not quit or I'm leaving."
Right. But that's actually a good point too. One of the reasons the clients may not want it to work is that change in identity, that change in being able to be present, to live their lives, because that's pretty scary.
Oh, yeah.
So, but but that's also on the client's end. From the clinician's end, this is what we were talking about. How do you know if it's really working? Phase 8 reevaluation, absolutely. But the other thing, and this is as much for the clinician as it is for the client, clarifying, what does a SUDS of 0 mean? A SUDS of 0 does not mean they're not sad, appropriately sad over the death of someone, right?
The event will always be sad. The event will be sad. Yes.
Absolutely. And but it doesn't mean no feeling. And that's what a lot of people think. It's like, well, they're still having an emotional reaction. Yeah, that's called human.
Right. And as you know, in our trainings, one of the things that we say all the time is what we want to do in EMDR reprocessing is move whatever experience it is, that horrible event, the sad event. We want to move that to it being an adjective about the event rather than a strong emotion in the body. So I can talk about it in a narrative way, past, present, future. A history, it's a historical truth. And the history is the incident may always be horrible. It will always be sad. But the issue is I'm not carrying the weight of that, the burden of that in my heart or spirit. I can acknowledge, I can talk about it. It's sad. Yes, it is. Children who are abused, that's never okay.
Right.
But they learn that, okay, I was an abused child, and I'm not being abused today.
Right. Today I'm safe. Today I'm good.
And I'll never let that happen to another kid within my purview.
Right. Right. And for those of our clients who truly are, for all of the reasons, all the memory networks they're dealing with, are people pleasers.
Yeah.
That may need to be the first target you go after.
Good point.
Right? And a cognitive interweave is something like, and if you do something that isn't what I want you to do, I'm not going anywhere. Right? That's a great cognitive interweave from a clinician. So.
And it's the idea that, the float back affect scan, have them focus on that need to please and have them then say, how about you just close your eyes and let your brain take you back to one of the very earliest times when you found that necessary.
Right? Because it's a great survival skill.
Yeah.
Especially as a child.
That's right. And speaking of children.
Yes, let's talk about kids for a second because they're different critters.
They're different critters and children. They'll often tell you, I'm 07 clear, because they want to play.
Right. As soon as we get done with this work stuff, I get to go play. Right. So so for kids, they might be lying to you. Just know that. So you might have to do some other ways to engage the kids a little bit more and to go, you have to do this for more than 5 minutes. Sorry. Now, having said that, kids do have itty bitty little tiny memory networks because they haven't been around that long. So it does go much faster than it does with someone who's 70 years old, for example. But you might have to push a little bit more and get them engaged and have them that the reprocessing, can be difficult, is engaging and fun and intriguing. And I want to stay here, not just, done. Can I go color now?
Yeah, and the other thing is that sometimes, they're doing sand tray, they're doing an activity, they're with a dollhouse, and in their play, they're beginning to replicate a traumatic memory, and the therapist, begins tapping or, other things while they're playing and are able to reprocess it at that time. And so it's a constant dance with kids between activity, reprocessing, that Deb Silveria, who talks about working with kids in our trainings, is so good about helping the kids move from one spot to another and take into account their developmental level. I will tell you a quick story. When I was first trained in EMDR, I did child clinical work for very early in my career, and I had this little girl that was sent in. She was like 5 or 6. Her parents sent her in because she was having horrible nightmares and waking up. We didn't know why. And so I decided, I'd have her talk about the nightmares, and we'd target the nightmares. And she was very scared in the beginning. And, after, 2 or 3 sets, short sets, she looked at me and said, okay, I'm all done. It's fun. It's good. And she started to giggle because the monsters in her nightmare had become cartoon figures automatically in her head.
Right.
Right. And so she was done. And so we finished the sessions doing typical play therapy things. And I was done. The mother said, well, how'd she do? And I said, I don't really know. She wasn't very engaged. She didn't focus much on what we were doing. So we'll see. I'll see her again next week. Well, between that session and the next session, the mother called and says, hey, she's had no nightmares. I think we're going to lay off on our sessions for a while. She's doing great. And that's when I learned about what you said. Short memory networks are small. And she went through it really quick. For real.
Mm-hmm. For real.
For
Mm-hmm.
real.
Yeah. And so this is what I want you guys, we're about out of time for our podcast today. But I want you guys to remember, like with kids, you're going to get those asking the caregivers the questions about what's different. With your adults or teens, what's different? What's changed for you since the last time I saw you? And going through any blocking beliefs, because I know this is a weird therapy, but it works. It really, truly works. So keep doing the good work, people. I'm so glad you're doing what you're doing, and we'll see you next time.
All right. Thank you.